Okay. Dr. Emma Thurston, thank you so much for joining me on the podcast today.
Pleasure.
I'm really looking forward to this conversation. I think you do amazing work, and
Thank you.
or maybe I should save all the kind of compliments for the end. But no, thank you so much for being here with me today. I want to start by just talking about where I first came across you, your work, and your PhD, which was at the Women's Health Symposium. When was that? Maybe a couple of months ago now?
Yeah, like July, I think July.
Yeah, it's quite a while ago now, wasn't it? So at that symposium, first of all, we heard from Professor Dame Leslie Regan.
Yes.
That's her name, isn't it? And she went through all of the issues surrounding women's health specifically. And to be honest, I was one of maybe 3 men in the audience, and the rest was all women.
Did notice that.
Yeah, and I did wonder, why that is, and maybe we'll touch on that a little bit later, like what can be done to sort of even that out a little bit. But yeah, so I was sat at the very back of the lecture theatre, sort of feeling a little bit like a sore thumb, standing out like one of the only men in there. But she went through all of the reasons that why women's health needs to be specifically addressed, as opposed to just like the health of people.
Yes.
So I just want to start by reading some of those stats, which was that 2/3 of carers are women, which is, I think, an important thing to note, because the health of women is also the health and happiness of everybody, because a lot of women are caring for everybody else, so when they're unhealthy. So that's the first thing I want to say. Half of the workforce is also women. I didn't know suicide is the leading cause of maternal death. Contraception is now difficult to access. I think since COVID, it's become more difficult.
I think it's been a challenge for a long time because of the way the service is funded, and it often falls through the gaps, like GPs or those trained in primary care to put coils in, and those in sexual health, which is also differently funded to the GPs, might be only be able to do it for contraception, where there's lots of different other reasons why someone might want a coil. But to get that, the funding's only in the hospital, so then you have to refer in, and women can fall through the gaps. And I think services are so stretched. I know, for example, working as a GP locally, I know if I say, yeah, we can get coils for you in Sexual Health Dorset, and it's an amazing service, they do so much, but they're so stretched. The women come back saying, well, I had to ring up at 8:15 on a Tuesday when I'm doing the school run to try and get on the list for a coil. So I think it's more pressures on the service and the way it's funded. There are annoyances, which I think a lot of clinicians find, that you are skilled to do something, but you're only allowed funding-wise to do it for a certain indication, which means women can be just going around in circles trying to get it.
So it's sort of like a systemic problem.
Yes.
In terms of how the process works.
Exactly, and I think we don't educate women enough as well about all the different variety of options available to them, and we haven't done the research historically to know all the different side effects. So women, and we don't know who is more likely to get a certain side effect than someone else, so it's a bit of trial and error, which, I mean, can be really empowering to tell women there's these choices, but it can be a bit frustrating when it's like, oh, I've tried this and I tried this and it is a bit of trial and error. So
why is there that disparity between who the tests are sort of run on? I think I saw something. It was called the gender data gap.
Yeah, gender
right?
data gap. Yeah, so there's a lot of work on this now, and there's an amazing book called Invisible Women, which talks about the gender gap as a whole, but she goes, the author goes really deep into the gender health gap, particularly, for example, how historically, thinking of like a non-gendered issue, heart attacks, the picture that we get to educate people to say, if you have this central crushing chest pain that goes into your left arm or into your jaw, then to seek urgent medical advice. We know now from research that women don't tend to get those classic symptoms, and they might get more anxiety, shoulder tip pain, shortness of breath, and those sorts of symptoms, which, because that's also how medics are trained about the central crushing chest pain, women are more likely to die if they do have a heart attack, because they end up getting the care they need later, because it's often not triaged in the same way. Misdiagnosed, and then delayed diagnosis, and then also women may not present in that, oh my God, I'm having a heart attack, urgent way to go to A&E, because it's not what they've been told from a public health campaign is the symptoms of a heart attack.
I think this is the reason that I wanted to start with this, the notes that I took from Leslie's keynote speech in that is because there were so many things that shocked me, And it really made me realize, okay, women's health and the sort of journey that women go through in life is much different to what men's would be, and I have no idea.
Yeah.
So I'll just continue with it, if that's okay. So our
Yeah.
teenage pregnancy rate is highest in Europe, in this country. 1 in 4 of our workforce are menopausal women, so it's important to look after.
And they often hit menopause when they're really in the peak of their career as well, which actually can be really devastating. Like, I run clinics where I'm seeing a lot of menopausal women and talking in their perimenopausal stage and postmenopause. And it can really be really devastating for them and scary if they don't know this can be a symptom of menopause, where they are in meetings trying to be really empowered and assertive in the right way in their jobs, but they just suddenly find they can't find the words, and in meetings that can be quite disempowering. But from an economical point of view, it's also really devastating to lose those women because they do end up leaving the workforce because of those feelings of that they feel incompetent, which is totally the wrong thing for them to feel, because they are so knowledgeable and so skilled in their areas by that stage of their life. They end up leaving the workforce, and economically trying to replace someone with all that knowledge and skills is just devastating. So yeah,
that was another thing that struck me with that keynote speech, was that she almost had to justify everything she said from a political perspective, the economic perspective, because otherwise people won't listen.
Yes.
It's like the individuals that are going through this don't matter almost to the the powers that be. There needs to be an economic you're grinning like you've had these conversations in the past and you know this all too well.
Yeah, exactly. Yeah.
It's terrible.
Yeah.
1 in 3 women over 60 have incontinence issues. Cardiovascular disease is often misdiagnosed, as you already said. Osteoporosis, a major cause of morbidity and mortality in women. 84% of women report not being listened to, and their symptoms were dismissed. Coronary heart disease kills more than twice as many women in the UK as breast cancer. And you wouldn't think that.
I think that's again the campaign marketing, and it sounds awful, but like breast cancer can be seen as like a sexy disease in terms of, for women, it's something that is, it's got the pink ribbons, it's got everything, and it's got that publicity, and it is so devastating for a woman to get it. But actually talking about how cardiovascular disease is the leading cause of death in women, women just don't know that, and therefore they're more worried about breast cancer because it is, it's so identity changing for the women who can have it. It can be, and it is a really devastating thing to go through. But women are more worried about that compared to actually what is more common. Yeah.
And like you say, it's because the big C word, as we refer to it, is all been sort of this push for cancer care and cancer treatment. But it doesn't necessarily reflect what's actually needed.
Exactly. And then I think there's inappropriately fear-mongering and not really making the public health campaigns appropriate to actually what the risk is.
So I'm not ashamed to say I actually sat at the back of that lecture theatre in tears when I was listening to all that, because it was just overwhelming for me, and it just made my mind completely shift and realise that no, we can't just treat everybody the same. And yes, women do go through things that men will not experience in their lives.
And I think on the flip side, men go through things that women don't go through. And I think that zero-sum game, putting the genders against each other, is never beneficial. And I think when I talk about advocating for women's health, I think you really need to, as an advocate for women's health, really need to always consider that men go through things that women don't understand as well.
So another thing, speaking of crying at the back of the lecture theatre by myself, another thing that brought tears to my eyes was your PhD research. And you said that young people learn, or women rather, are taught that sex is about others' pleasure and satisfaction. That teenage girls and boys learning from porn believe that sex should be painful for women. And that a 14-year-old boy accused of rape stood up in court, and when asked why he didn't stop, said, "I thought girls always cry during sex." How big is this problem of sort of youngsters learning about sex? What are the causes, and what are the solutions?
I think it's a big problem that I think is under-recognised in many. I think particularly because as the generations have changed, porn has changed from the medium that it's delivered in, and smartphones has made it access to everyone. So the Children's Commissioner, the government's Children's Commissioner, produced a report about porn and the access and influence it has on young people in schools. And I think there's two overarching themes behind the issue. It's massive deficits and gaps in sex education, meaning that children and young people and adolescents are wanting to fill their gaps, understandably, and learn more about sex. And then they're using porn to do that because it's easily accessible and you literally can just Google it and find it. And then they're using porn as sex education. Now, porn is not sex education. It's in the name. It's the adult entertainment industry. It's meant for entertainment for adults, and it's meant to be a total fantasy, not necessarily something you would depict in real life sex acts. It is for those who understand the difference between this fantasy world and what real life sex looks like. However, when young people are using it as their sex education, they feel that it's very often extreme versions of porn are what sex should be represented as. And some of the studies I quoted in that talk I gave was that 44% of people who had watched porn, as in teenagers, were therefore asked, if their partner had watched porn, 44% of people were asked to enact those porn sex acts that they saw in porn in real life settings. And for example, we've seen a massive increased rise in choking, because choking is seen in porn and it's sort of an act within BDSM often, but people aren't given the education about what actually this is, what it means, and all that. And it's actually a really dangerous thing to do. People have died from choking during sex, but it's depicted as this normal sex act within porn that therefore young people go and try. And I think I'm not anti-porn. I'm anti-porn being used as sex education, and I'm anti-porn that's free. I think there are some really great people trying to make porn that's ethical and feminist, and everyone's consented to, knows what's, in terms of the actors who are working in the industry are well paid. There's, STI tests, everything is consented to before, and there's like debriefs afterwards to make sure everyone was sort of happy with their experience. Sort of like Erica Lust is a big well-known name in that field. However, the porn that young people have access to, because that ethical feminist porn is behind a paywall, and if you're not paying for your porn, then actually you're more likely to be seeing the free stuff that is tailored to the male gaze. And it's like anything in terms of YouTube spirals or, I don't know, Instagram, there's like a wormhole that you need to get more and more extreme to get your attention. So, but if you just look at like Pornhub or other porn sites are available, like, you look
Don't
at
make me list them.
if you look at the home pages, they're really extreme acts. And actually, again, another one of the statistics I quoted, and I think what you call extreme will vary from person to person, but researchers did some analysis of just the porn that you would see on these the mainstream porn websites, and over 80%, I think it was 88.2%, were misogynistic and violent. And if that's what young boys and girls are learning is porn, I think it's really sad, and I think it's quite dangerous, and we need to teach them. So in terms of your initial question about how we improve this, I think we improve sex ed so there's less void for them to be going to, but we have to teach porn literacy as well, because yes, there's the online safety bill coming, but actually these are generations who are so much more technological and literate than we are. So therefore they're probably going to be able to go around all these things if they want to. So we need to teach them what porn is. And I don't mean we're making teenagers in school watch porn. That is not what I'm teaching. It's just teaching them that this is not a representation of real consensual healthy sex. This is for fantasy, often for self-exploration, solo pleasure, all that sort of thing, but it's not actually a representation of what real life coupled sex looks like. And it's really damaging from not only the violence and teen dating violence, but actually expectations, and it makes sex so much more performative and not actually less embodied and enjoyable, because they're worried about what they look like. So for example, the rise in labiaplasty. So if I say labiaplasty, you've got a puzzled face, I just want to explain it. So it's basically cosmetic genital surgery for females. So they have porn actresses are often either digitally or surgically I'm going to use in quotation marks, enhanced. So their labia are small and symmetrical, and that's then become the ideal standard. Whereas then you can get body dysmorphia and just real body negativity and feelings of insecurity around labia if they protrude. So I'm talking about the inner labia, so the labia minora, if they protrude to a greater extent than the outer labia or the labia majora, or if they're asymmetrical. And it's totally normal to have asymmetrical protruding labia, and every single one is different. It's like snowflakes, like everyone is different. Whereas women get this perception, or young girls get this perception of that is the perfect one, and therefore they're seeking out to be cosmetically cut. Which actually can, the labia minora are massively erogenous tissues. They get engorged when you're sexually aroused, and so they have a real value and a purpose. Whereas actually if you get cut, again, because of the lack of research in women's health, it's only recently that we're really understanding the anatomy of this area, and then you're having surgery to cut, and you're like, well, actually, do we know that the cutting's been done in the right way from a nerve supply? And there's risks with all these surgeries, like bleeding, persistent pain during sex, all these different things. And actually, women could be trying to get them before they've finished their pubertal development as well. So there's so many long-term potential negative outcomes. And yes, there might be a very, very small minority of people where this is medically indicated, but for the vast majority of people, it's due to insecurities from the cosmetic point of view, and a lot of that is coming from porn. And the other thing is porn perpetuates this heteronormative, to a degree, I think. Sometimes porn can be useful for seeing depictions of non-heteronormative sex when people maybe not feel that they have that understanding or vision, particularly if they are wondering about their gender or sexuality. It can be actually really empowering for them to see depictions that they think is more encompassing with their gender identity. However, in the heteronormative scenes within porn, it's very, again, male gaze, so focused on the male pleasure, so it's very penetrative, when we know that less than 20% of women actually will orgasm from penetrative sex alone, because that is just our anatomy. It's the clitoris that is going to give us pleasure, whereas actually the vagina actually doesn't have that much feelings, because, think about childbirth, you don't want that much feelings. So actually, it's very perpetuating these myths about female pleasure, but then within about 2 seconds, well, I don't know, but within a certain short period of time, which is very unrealistic in porn, women are seen orgasming from penis thrusting within 2 seconds, and it's like simultaneous orgasms within 2 seconds. So it's a real unrealistic depiction of sex, and actually it's not good for men either, because the male actors in porn are, again, specifically chosen for being right at the far ends of the normal distribution curve in penis size. So you might have 7, 8, 9, 10-inch penises when they're erect in porn, whereas actually the average male erect penis is 5.5 inches. So then men go and feel really, inadequate. Yeah. And it's just not healthy for anyone. And then you get all these insecurities and performance-based sex, which is really not what sex is about, in my mind.
Do you think this is a problem with the internet at large as well? I mean, social media has a very similar effect, but obviously not in terms of sexual organs or whatever, but in terms of just body dysmorphia, as you say, and feeling inadequate. I think it's going to get worse, because probably more people are using filters these days on their faces and whatever else. And it's giving everyone this unrealistic expectation of what it is to be real and to be human.
I think there is very much that comparison culture in, say, Instagram. It's very pictorial.
That we didn't have, I mean, I don't know how old you are, but I'm 36, and we didn't have that when I was growing up. No, it just started to come in as I was sort of 20-ish.
I'm really pleased I didn't grow up with that, I think.
Yeah, me too.
I think, though, if you curate your media feed in a way that's positive, and if you think that you're leaving social media feeling better than when you went on it, I think you're doing a good job, and I wouldn't recommend being on it for too long, but just there's more to life than looking at a screen. But actually, there are some people who find that they find their communities on social media that they haven't been able to find in their own physical, locality, and particularly for more, marginalised views or communities. And I mean that in a positive and negative sense. And I think there is really good encouraging social media feeds as well. So I think there is some positivity out there, but I think it's about learning how to create it so you feel better when you've left social media than when you've gone on it.
Yeah. Which takes a level of introspection, which I think I probably lacked when I was young, and I fear that, I mean, as I said earlier, I've got 2 young daughters, and at some point in their life, I'm going to have to cross this boundary of social media and all this stuff. And I just hope by that point, when they have to deal with it, that they do have that level of introspection to say, hang on, I spent an hour on social media and I don't feel good.
Yes, exactly.
So maybe I'll reduce.
And maybe in life education, we need to include social media literacy as well as porn literacy and all that sort of thing.
Well, and that's what I was going to say actually about, you said about sex education addressing the porn as well. but sex and porn is such a taboo subject, and I think to me it seems like prudent British culture is like, oh, we can't talk about sex, especially not with our children.
Yes.
How can we resolve that? Yeah, solve it.
I'll
can we...
tell you in about 6 years when my PhD's done.
Is that what you're trying to solve with your PhD? Right.
Yeah.
Wow.
Well, I think, at this stage, I'm very early days, so I'm kind of really looking to see where the literature's been and what the gaps are, and then where I can really focus it. But I think the shame and taboo is one of the massive issues, and I think that's not only from the sex, but from women's health more generally. Shame and taboo about periods, particularly when it's really not something to be shameful about, and it's really...
I found it disgusting. I think it was a female tennis player, bit of blood on her shorts, and it's like headline news or something. You know, it's in the newspaper. It's just, I don't know, it's just disgusting that is newsworthy.
Yes, yeah, exactly. And it's something that, yes, there's contraception, which means things can be very different, but, half of the population will probably bleed for about, half to a quarter of their life, so it's actually like something that happens.
Come on, let's get over it. Yeah, exactly. Let's understand this.
Exactly, and I think it's so societal taboos and shames like that. I think British prudishness is probably a factor. I think religion has an aspect to blame as well. If you look at the Bible and other religious texts, there's aspects of women being dirty at that time of the month, and being shunned into. Like, I think it's really sad in Nepal, even though the practice has been made illegal, women do still get put into the sheds in the Himalayas when they're having their periods. They're not allowed in the house, and they're not allowed definitely in their partner's bed, and they have to go and live out in different, like literally shacks whilst they're bleeding, which really impacts their education, because women, obviously the girls can't go to school when they're doing that, and women have been raped, murdered, and just died of cold and starvation in those huts, and it's so sad. It's happening like this year as well, and it's just so sad that we're in this stage of life, and we're in 2023 and that is still happening.
I'm quite shocked by that, sorry. Crikey. I mean, most of this conversation is quite shocking stuff. And as I say, I learned some of this at the Women's Health Symposium, but maybe people listening, this is new to people listening as well. So you focus a lot of your research on sort of sexual agency as well. Can you discuss what that means?
Yes, I think, thankfully, consent is kind of becoming much more mainstream, and I think is within the curriculum. So the Department of Education produced in 2019 an updated curriculum for the relationship and sexual education. But of note, pleasure was not mentioned as a single entirety of that document, because I did look at it and read it, but consent is in. But I feel like having consent as like this gold standard is really, I don't think, helpful either. I feel like consent should be like the very basic low bar to any sexual encounter, rather than like, if you got consent, this is great sex. I'm like, no, actually that is the lowest of the lowest bars. And I think agency encompasses so much more than that. So it's yes, consent, but it's also power dynamics within any partnered sexual act. There is, and that can be gendered, that can be age related, that can be hierarchical within a working environment, all those sorts of things. So power dynamics within that relationship. And for example, the quote again, the surgical Me Too came out last week. So there was a paper published about how surgeons had been sexually harassed and coerced into sex for career development. Anyone working in medicine knows about it, but it's just actually been published in the newspapers last week. But then you've got the societal norms about, kind of like I was talking about, and what Dame Leslie Regan was talking about in that women's symposium, about how if you are a female outwardly presenting person, you are kind of taught throughout your life to put the values of others above, be a people pleaser, and be polite. And actually, if you are taught to be polite, I think there's a contradiction between being polite and saying no in sex, personally. I think actually, if you've said, I'll do something, and then it's like that withdrawal of consent, actually, if you're taught to please someone else above your own, you might put up with slight pain during penetration or sex, because actually that's what your partner wants and pleasing. So it's all that socio-cultural power dynamics, as well as the basic consent, I think, is sexual agency, as well as knowing your own anatomy and knowing your own body. Again, I think masturbation, I prefer to call it like solo sex, solo self-pleasure, all that sort of thing. I think that is, generally speaking, considered okay for guys. And, you know, growing up, again, I didn't grow up as a guy, so I don't know in terms of what happens in terms of socialization, but I think it's kind of expected as a teenage boy and not really stigmatized. But again, I don't have that latest experience, so I'm happy for you to, you know, tell me otherwise. But
I would say, yeah, and you know, lads joke about
yes,
it
exactly.
with each other and stuff. Yeah.
Whereas it's quite stigmatized and taboo for a girl to masturbate or self-pleasure. And actually, how on earth, unless we've explored our bodies, can we direct a partner to say, this is what I like, or this is how I get pleasure? And actually, partners might like that guidance. So instead of being like lost in terms of how am I meant to, you know, again, men have that, I imagine again, men have that pressure of satisfying their female partner. And actually, unless there's some guidance from the female partner, that can be a whole lot of more guessing. And actually, there might be some fun in younger age sex, or when you're in your sexual debut, learning how you receive pleasure with someone else. And actually, if that's fully consensual, yay, go for it. But actually, if someone does want help, say, like, tell me what you actually like, unless you've actually explored your own body, how are you meant to say that? And it's something so empowering about actually knowing how you receive pleasure. But we're teaching a very reproductive model of sex. It's like, here's your internal organs. I mean, it's women's internal organs, by and large, don't give them pleasure. I mean, yeah, you can get cervical orgasms, you can get vaginal orgasms when they're all internal, but actually it's the clitoris and the interaction within these structures that actually would teach girls pleasure. But I hope sex ed has gone on, but pleasure wasn't named in the sexual relationship education. And I know very well from my sex ed, no one even told me that I had a clitoris. So, you know, in terms of actually, if we're not teaching women they even have this body part, because it's not like a penis in that, in the vast majority of cases, it's more hidden than a penis. You know, actually, if you don't teach people that they have these structures, most girls find it from, you know, children self-pleasure to soothe themselves and stuff. So most people will find it, obviously, but it's not a focus of attention compared to the vagina and the uterus and that sort of thing.
What sort of part do fetishes and kinks play when it comes to, you mentioned the power dynamics and consent, and correct me if I'm wrong, but it feels like a common fetish for a woman is to be controlled by a maybe more domineering man or someone of high stature or something like that.
So, yeah.
Does that complicate matters when it comes to those things?
I think if it's done properly, no. So kinks and fetishes are kind of within the BDSM umbrella,
or even just fantasies. Maybe
yeah, exactly. So there's difference, because kinks is more things that turn me on, whereas fetish is a necessary to be turned on. So they're slightly different.
Oh, okay. I had no idea.
So and I think we can actually learn from the BDSM community, even though it's considered, again, quite taboo. And I think recent depictions of it, say like 50 Shades of Grey.
What does BDSM stand for?
Well, there's actually a few different ways you can interpret it, but bondage, domination, submissiveness, and matricism. I can't really say those words, but yeah. So yeah. I think I know what you mean. And then there's sadism as well in there. So there's the basically power dynamics, the bondage element, so tying people up, and then the pleasure from inflicting or receiving pain. That's kind of the overarching names. But actually, they deal with consent very, very well. And I think we can not teach children how to do BDSM. I think that's going a bit too far in my mind, I think, you know. But I think actually teaching them some of the principles we can learn from that community, in that every act is actually consented to before. So it's not, can we have sex, and that encompasses everything, and then you've consented to everything. It's like, actually, would we like to do this sex act? Would we like to do that sex act? And having boundaries clearly stipulated. I think that's something that actually could be learned from that community and brought into everyday sex.
So that's like really explicit consent. Yeah. It's almost like you're signing a bit of paper. Exactly. It's very explicit like that.
And I think actually, again, consent can be so made to feel so unsexy, whereas actually there's so ways of incorporating it where it's a real turn on, and actually it's in knowing your partner in that. Yes, if you're in a more, say, casual relationship, one-time thing, hook up, any of those sorts of things, you might not know your partner enough to really know their non-verbals to actually know whether this is affirmative consent or not. However, and therefore you might adapt your consent style according to how well you know your partner. But actually, if you know your partner in a very long-term relationship, you know, their moans, their eye contact, their nods, you probably would know a bit more than in someone you haven't got, you know, that relationship with. But then, you know, there's such a, even simple things like, do you like that? You know, and you can say that as sexily as you like, but actually that is...
Don't make me try.
No, I won't do it. You can see I didn't do it. You can, you know, incorporate it like that. And actually, it's then the agency thing is teaching someone to say no, and teaching the person who said no to accept that as graciously as they would have accepted a yes.
And also it comes back to the exploration with your partner thing as well. You're exploring what they like and what they don't like.
And I think with that power dynamics again, and being taught in a you know, growing up as a female and being a woman, there's always that slight fear that if you say no, that's going to be poorly received as well. So that's part of the power dynamic as well. But I think it's teaching people to graciously accept no, but also to teach consent, like that actually it's, yes, the lowest bar of a sexual act, but actually it can be incorporated and be really sexy and really affirmative.
I think maybe part of the problem here is that it takes a certain level of maturity to approach this conversation, and the fact that sex is a taboo subject on top of that culturally, to overcome that taboo and have this conversation, especially when you're young and maybe losing your virginity for the first.
Although virginity is a social construct, but
well, yeah, of course. Okay, educate me. Okay, so I mean, virginity, I suppose, is a social construct, but I suppose people sometimes off the cuff use virginity for anything, like, you know, I lost my bungee jump virginity.
Exactly. But I think it's very heteronormative, because is a 40-year-old lady who's only ever had sex with a lady, quote unquote, virgin, because she hasn't had a penis in her vagina.
Yeah, and I think there's this myth, isn't there? Is it the hymen? Is
yes.
It? So you tell me.
Yeah.
I don't want.
A bit anatomy. There's like, I think it's an embryological remnant. So when sort of fetuses are growing, the canal kind of actually gets created from the sort of more inner part to the outer part, and sometimes there's a leftover little bit of skin around the outside, but it's not this like covering. Actually, if it's a covering that needs to be like quote unquote perforated, that's called an imperforate hymen, and actually it's like a medical problem, because actually menstrual blood can't leave the vagina if there's a covering there. And you know, many people have their first periods before they have sex, so you know, particularly as the age of periods are going down and down, like girls as young as 9 are having their periods now. So, you know, I think, and there's different shapes. So you can get crescent. Let's make a note of that. It's like, I've got daughters. There's like imperforate hymens, but then there's crescent shape. So it's more like a bit of skin around the entrance of the opening, but it's not something you need to penetrate. And actually, some women have had birth and still have an intact hymen. And actually, women aren't necessarily going to bleed on the first time in sex. And actually, if they do bleed in sex, it's actually probably lack of arousal, or, you know, not fear, but that anticipation of it potentially hurting makes them tighten up, and a bit of, you know, vulval vaginal trauma is actually probably the more likely cause of sex than any hymen related.
So why on earth did this hymen thing ever become it sounds like it's such minimal.
I think it was to control women, in my mind, in terms of, and then actually there's this whole hymen testing thing to check if someone's, you know, a quote unquote virgin, and that's been sort of made illegal in the UK. It still happens in some places, but in some cultures you're still, you know, hanging out the blood-stained sheets after the marriage night. And if there's no blood, then there's real problems. Obviously, women have come up with ways and means to resolve that issue, but the expectation of blood again is also perpetuating the fact that women should be in pain during sex.
So periods, as young as 9. Why is it going down?
Variety of possible reasons, as always. One is estrogen's also released by adipose tissue, so fat cells, and as children are becoming more, there's more preponderance of childhood overweight and childhood obesity. That tipping point in sort of setting off that hormonal axis within their body starts earlier because they've got more estrogen from their fat cells, and also the environmental hormonal dysregulating chemicals that are within our system.
What does that one mean? Sorry, that
so
last
like
bit you just said.
so there's chemicals within our world generated by men, like plastics and BPA. I think you can often buy plastic cells like BPA free. They are hormonal dysregulators. Right. So lots of all these things like perfumes and all these things we put on our bodies and cosmetics kind of have some evidence. It's not something, not my massive area of expertise, but there's products that we use and are in our food chain or in our cosmetics that disrupt hormones, and that's one reason why it's proposed that girls are going through puberty younger, but also why, for example, there's a decrease in sperm motility concentration across the decade. So to the point that WHO, I can't remember the exact day, maybe 2019, I think. There was 2015 and then 2019. Have actually reduced their normal parameters for sperm. So if you're doing a sperm analysis query like infertility or something like that, and actually they've reduced how, like, the percentage of good sperm and how much sperm's needed in an ejaculate to actually be considered normal because it's just going down.
that's quite a big problem.
Yes.
Really, for
Yeah.
humankind,
Well,
isn't it?
I mean, it depends what side of the debate you're on in terms of human population and all that. But yeah, if people at an individual level, if
Oh, I see what you're
women
saying. I was trying to think what sort of
overpopulated,
side of the debate you're talking about.
Yeah. There's some people who debate that we're, the world's overpopulated.
Yeah,
and
that we're like a cancer to the earth.
Exactly.
Or something. Yeah.
So but taking it at an individual level, if there's, the rate of infertility, which medically is unable to conceive naturally with regular penetrative vaginal penis and vagina sex for a year, that is going up. It used to be, say, 1 in 7 couples, now like 1 in 6 couples have some element of infertility. That doesn't mean they will never be able to have a child, because actually if they continue having regular unprotected sex for 2 years, the natural conceiving rate does go up, but just that's some
just
challenge.
based on frequency.
Yeah. Well, in terms of number of possible chances, really, in terms of eggs being released, if that is happening. Yeah.
Okay. Can I ask you, when did you learn to speak about this stuff bluntly and without any kind of shame or embarrassment?
I think probably in the last 5 years, 4 or 5 years. Yeah.
Okay. And do you see that as part of your journey?
Yeah, exactly. I think
becoming accustomed to this stuff.
Being shocked at how naive I was as a teenager, I think really made me feel wow. And then reading so much about it, people like my bookshelf, and then realizing how.
So I'm just picturing your bookshelf.
Yeah, exactly. But realizing that I'm not the only one, particularly with patients coming towards me. So I do a lot of women's health. I do a lot of perimenopausal care, and I think a real vital part of that is asking women about how their sexual health might have changed during that time, because there is potential low libido, but also more pain with sex, because the lack of estrogen means those tissues can be really. Estrogen helps support the lubrication of the vagina and improves the thickness of the vaginal wall, so it's less when the estrogen's lower or fluctuating. It's mainly more postmenopausal risk, it's due to the low estrogen. The skin around the vulva, particularly the vestibule, which is like the vaginal opening, can get really friable, which then leads to painful sex. But unless you ask women, again, because that's societal taboos, then they don't really come out and ask it. And then I learned about all the different things you can do to improve that. And it starts with using lube. And actually there's studies that show using lube, so all the different types, water-based, oil-based, silicone-based, different uses and pros and cons for each. But they can massively improve those symptoms for those women. It's such a simple thing, but actually any vulva owner is 70 to 80% more likely to orgasm if they use lube. So I say from your, if you're 16 or 96, you should be using lube. And then there's vaginal moisturizers, which you can use, which is more hyaluronic acid. So what women put on their face is face moisturizers, but you don't moisturize your vulva, and that can really help this genitourinary syndrome and menopause. But then there's also vaginal estrogens, but they don't come out with that because of societal taboo, but no one's actually taught them this, that actually they think, oh, it's just something to live with as I'm older. And I'm like, no, there are so many things we can do. And it's empowering them with that knowledge that then they can try the things that they can try at home, but then come if they want to treat support from that more hormonal things. Or I actually always say, if you are suffering this, always get checked out with your doctor first, because yes, vaginal estrogen is now available over the counter, but actually there are some other skin conditions of the vulva which can mimic those symptoms. So, and they get treated very differently. So I always say, have an examination, and then by all means go on with it. Go on with vaginal estrogen. We can prescribe that, but I think it's always worth getting checked out first if you're going to think new, just to make sure that we're treating the right thing rather than self-treating and potentially treating the wrong thing. There's something called lichen sclerosis, which actually, if you don't treat quite, I don't know the word aggressively, it's only steroids, but you have to treat it quite intensely. And then be on a maintenance dose, and because otherwise the architecture of those external genitalia can change, and it is a potential for increasing the risk of vulval skin cancer. So you really want to, make sure that you're treating the right thing, basically. So that's why I emphasise that. But it's really important to teach women about this, and I feel like I was having lots of women come to me with really easily solvable issues if there was just education, and that made me empowered to read about it at the different life stages. So one of the women's health strategies, key buzz term, is the life course. So you've got pre-pubertal women, you've got when they reach puberty, you've got their contraceptive needs, their sex education needs. During their fertile years, you've got their contraceptive needs, and then if they do decide they want to have a family, they've got the fertility aspects. And again, that's something we don't teach anyone, is how to get pregnant. We teach them a prevention, an STI and pregnancy prevention strategy. That is basically what sex ed is. And then consent put in there as well. but we don't teach them actually what you need to do to get pregnant if you want to. And then you got that perimenopausal phase of life as
when
well.
you say what they need to do to get pregnant, you mean in terms of like times of the month and
yeah,
this sort
so
of thing?
people don't actually understand, and women as well, who are actually having these changes when in a menstrual cycle, they're more likely to get pregnant. They don't learn how that is related to them and their own menstrual cycle. You don't realise all the lifestyle things that you can do which massively impact your fertility. So if you're obese, that will massively reduce your fertility. If you're a smoker, if you drink alcohol. But actually, if you're trying to get pregnant, the things that you would need to do to try and support that pregnancy, or not need to, but is advised to. So, supplementing with folic acid, like a pre-pregnancy multivitamin. But then also things like exercise, it can really boost your fertility. Stress management, how stress really, really impacts infertility. So all these different things, but I think particularly that menstrual cycle awareness, because it's so taboo, because everyone's calls and actually we don't even say the right words. So if I'm doing consultations, I would say, how long is your period? And people will say like 21 days. And I'm like, does that mean you're bleeding for 21 days? Or is that from the start of the first day of bleeding to the last day before your next bleed? How long's that? And actually, it's just that terminology we're not even teaching them. So we don't necessarily have that body knowledge. And I think a lot of this comes back to actually body knowledge and teaching women, from my perspective, actually their own bodies, and actually therefore being able to enhance that for sexual pleasure, agency, and just actual life in terms of, how to avoid pregnancy if they don't want to get pregnant, but also how to get pregnant if they do.
Whose job is this to educate people?
It's a really interesting question. I think it's actually society as a whole. I feel we need to remove the shame so we can actually talk about this. I feel that, if you are going down the route of having a child, I feel there is some definite parental responsibility there. But I do appreciate that not every child is going to get that from their family. So I do feel there's some room for, within the more formal education space, and now young adults have to be in some form of education until 18. So you've got that 16 to 18 window where actually having sex is this, legally allowed, kind of probably expected, some sort of sexual exploration time. And actually giving that in education is in a formal education can be valued. And actually, if in terms of some of the focus groups that were done to go behind the women's health strategy and kind of give evidence for the recommendations they gave, a lot of women said, education, school setting was where they would like to learn this the most. But obviously parents is, I think, often involved as well. And actually then there's a lot of debate around that as well between parents and school situations.
It could be quite embarrassing, I imagine, for a kid. I'm imagining that scene in American Pie where the dad sits on the bed and says, "Son, we need to have a talk."
Exactly, and I think it shouldn't be that one talk. It should be just influence, and you can teach consent. And this is the age appropriate. You often hear age appropriate in these conversations. You can teach consent to 3-4-year-olds. It's actually, do you have to hug your uncle even though you really don't want to? Or could you just wave or give a fist pump? And actually giving the child the choice rather than being forced to do something they don't want. And that reduces their bodily autonomy.
I think about that regularly.
Yeah.
when go and say bye to your nan.
Yeah.
Go on, go and say. And it's like, if they don't want to, just leave them.
Exactly. And actually, it might be hurtful as a parent or as a family member if a child doesn't want to give you a hug. But actually, why is your feelings of hurt more important than their bodily autonomy? And actually you can teach children at such a young age. It's also like sharing toys. It's like, oh no, it's his toy, give it give it back, or do you want to share, and that sort of thing. And there is teaching sharing is important, but I think there's an element of incorporating this not just about sex but body autonomy for all that, everything like that, at an age appropriate level, and then it just becomes part of the conversation going on.
So big cultural changes, I think, that are needed really for this to...
And I think social media can have a role, but the problem with social media is there's good and bad. So actually there's good resources and they're bad, and actually people who are ignorant from no fault of their own don't necessarily know which they're getting when they're reading it.
And I know you're talking a lot about women knowing their own bodies and knowing all this stuff, but I think there is a need also for men.
Oh, absolutely.
And, younger men even to understand so that they can empathise.
Exactly. And I think it goes both ways. I think, I think women learning about some of the issues. And I think they're...
Yeah, although I would say that... I mean, sitting in that lecture again, just coming back to that, it just was so eye-opening to me. As a 36-year-old man, I've lived my entire life knowing that, women have periods and stuff, but really not fully
Oh, God,
I mean, still
yeah.
not fully grasping, obviously, but having at least some idea now of that journey,
Yeah,
which is what
and
you
I
were
think it would
discussing a
improve
moment ago.
empathy around people. But I feel like, you know, how many women have like shoved a tampon up their sleeve in the office to go to the room? And, you know, if you could just like actually take a period product with no shame, it would take so much easier. Particularly there's loads of different ones now as well, which is great. But again, we need to teach women about those and the pros and cons of all them, you know.
Some heavy stuff. We've discussed that. Okay. Shall we move on to a slightly different topic?
Yeah, please do.
You, I think you run the Women's Academic Network, do you? Am I right in
Yeah,
saying that?
I co-run it with Jo Mayo. She's great.
Fantastic. I'll have to have her on the podcast sometime. So the Women's Academic Network,
Yes.
Can you explain what that is, like what your goals are, what your mission statement is or whatever?
Yeah, so we have a co-convenor team. So Jo is obviously heavily involved as co-lead.
I should probably contextualise this is for Bournemouth University.
Yes, not for like the country.
Yeah.
Yeah, and then we have a team of other co-conveners who do come and go. And I only joined recently because I only came to the uni 18 months ago. So but it's basically to try and provide a community for women academics, because particularly historically it's been a very male-dominated field, and there's certain challenges which are unique to women academics, to try and promote the work we're doing, get other interesting speakers out, network, and just try and minimise the barriers as much as possible. So it very much works into the Athena Swan, which I don't know if you know about. Yeah, exactly.
You can go into that if you want to. Though,
so Athena Swan is a charter which is trying to promote gender equity across all higher education institutes, both nationally and in other countries.
Is it just gender equity, or are there other things?
So there's the race charter as well, but that's not actually. I think Athena Swan is the gender charter, but then there's like the race equity charter, the disability champion. So there's lots of different charters, but so it feeds into that Athena Swan work, but it's very much distinct from that in terms of who runs each and sorts of, But I do sit on the Athena Swan steering committee as part of my role as the WAN representative for that.
So what are the main challenges that you feel like you face when people join the Women's Academic Network? What are you mostly doing with them to help them?
So it would be, I think the writing retreats which Jo run are amazing. So that's providing designated space where women can really focus on their work. So at a national level, I'm not talking about Bournemouth University, but women academics, because they have that more, like you were saying at the beginning, that caring role in society, they often are then given responsibilities of more, say, personal tutoring, and they give more time to that because they feel either more heavily invested or I don't understand them. I don't know the research into the rationale behind, but they tend to find that they are given more responsibility and take more time doing those roles which aren't considered so important when going to promotion boards, for example. So they do more of that time, effort, mentoring in a more mothering role to their students.
Like a pastoral.
Yeah, pastoral role, yeah. And therefore, say, for example, they might have more of those interruptions throughout the day. So actually giving women the writing retreats where they can really, unplug, focus on their own work in a very supportive space is really, I think, empowering. And a lot of women really like that. They find working together with people who are like, silently working can actually really impact their productivity. So we get loads of really good feedback from that. We've had some really interesting external speakers. We try and put something on for the women's International Women's Day. So last March I arranged for Sarah Graham, who wrote the book called Rebels' Bodies, which is about gender inequity within healthcare. She came and did like a panel presentation with that, so that was really interesting. And then we do small grants. So any academic who is a member of WAN, who has some research which is in line with our values, can bid for normally £500 to go towards some research to help them in terms of progress their projects or research or that sort of thing.
My colleague Ros took advantage of that. Yeah.
Yeah.
Well, I went out for dinner with some of our colleagues last night, and she said, "Oh, I know Emma." When I said, "I'm meeting you tomorrow."
Yeah.
So yeah, that's really great.
And then we funded as part of that the women's health in Dorset research the symposium that you came and are speaking at. Yeah.
Oh, okay. So that also went through the Women's Academic Network. Oh, fantastic. Okay, so what would you say to those who question? I mean, you sort of justified it already. Maybe who might say it seems exclusory to have things called women's ... or whatever. How would you answer that?
I think it depends on who's asking me that and what their rationale is for it, and
Very good response. Yeah, I like that.
What were they hoping to, in terms of, do they feel discriminated in a different way, and is therefore they want some representation, or is it just a generic comment? And I feel like it depends on where they're coming from, how I would tailor my answer. But say, for example, there was a young man academic who was saying, well, I feel like I don't have a space here, or I feel like I'm not, privileged in any way versus you, so why are you getting this sort of academic? No, I would say that from my perspective, I don't think women are the right people to form a community to support your individual challenges, because I have no lived experience and I have not that, therefore, level of empathy of what your needs are. So by all means, set up a young male academic network. That is absolutely fine, but I don't think it's the responsibility of women to do it in terms of how much time and effort it takes to run these sort of things. But also, I don't think I'm the right person to do it, because I don't have that empathy and lived experience for you. And maybe, I feel like, no, times have changed. Society has moved on, and we can see with the rise of, say, like Andrew Tate and all those sort of influencers, that there is a space left for young male where they feel like women have taken over some of their roles historically been, in terms of like the breadwinner and all those sorts of things. But it's therefore the responsibility, I feel, of the older men who maybe had that privilege to feed back into the young males, actually try and help and provide good role models. So we're not looking up to Andrew Tate and all those sort of people, to provide really good role models and help the young men coming up, rather than leaving that for the women to do as well.
Yeah. Could you just watch your cable on the
Sorry.
mic? It's tapping it, but maybe
I gesticulate too much.
No, I think that's a really great response. How do you think it would be received if someone created a men's academic network, for example? Do you think that would go down well, or do you think it would be seen as provocative because it's like...
I think it depends what their values and aims were. Yeah.
And if it was genuine and because to be honest, obviously I'm a male. I do often think about the young men particularly, and all that Andrew Tate stuff, and providing positive role models, and also the fact that I suppose the health issues, as you say, and the caring roles that women tend to have. But there are probably lots of men who have a similar scenario there, but then feel like there's no avenue for them to maybe have the respite from the caring role that they do, or that sort of thing. So I don't know. I had this similar thing with Professor Carol Clark, who came on, and I asked her, how do we do this without kind of like dismissing certain people? And I don't know. It's probably a bigger problem than this conversation can solve. But it's something that I ponder over, probably because I am a man.
Yeah, exactly.
And I also want to progress in my career.
Exactly. And I think we don't want to discriminate against anyone, but we want to make sure that everyone has, equal opportunity, acknowledging the different roles and responsibilities they have in life.
Yeah. Okay. Lovely answer. Well done. Well dealt with.
Thank you.
So what did you do before you came to the university? You said you've only been here 18 months?
Yes. So GP, medical training takes a while. So from leaving school, I went to Oxford Uni, which is 6 years, to do medicine. No gap year, just ran straight through. And then I did foundation year, which is 2-year full-time training. And then I was really torn, because I always like this bigger picture thinking. I really was torn between going down the public health route or going down the GP route, because I also like that continuity of care. I like holistic medicine. I think that in the NHS, GP is potentially one of the ways you can get it. Not that I don't think in 10-minute appointments you can't really, but and I'm a doctor, but I don't really like hospitals, so
really?
Yeah. So it was either GP or public health.
That's unfortunate.
Yeah. And public health was still. I just had a thought going on.
My wife is a PE teacher, but she's allergic to grass.
Oh God, yeah, exactly. Bad
Same sort of
term, yeah. But
sorry to interrupt.
No, that's fine. But yeah, medical training is quite life. I don't want to say destroying, but disruptive in terms of that. You get sent anywhere in the country where they need you, and you can rank them, but you don't get a choice ultimately. And one of the things that drew me away from public health was that I really wanted to just have a house by that point that I could call home, and you would still have to move, say, between Southampton, Portsmouth, spend a year on the Isle of Wight, Dorchester. So it was either move or have really long commutes. And I was thinking, is that something I want to do? And also at that stage, the funding from public health was going more into local authorities, and the spending over the last, I can't remember exact stats, but like 10 years, the public health funding is reduced by like 17%, just regardless of all this, need. So I was like, job security, is that going to be a problem? So what I did is I did my GP training part-time. And I've always been a bit of a nerd as well as being an academic, you could probably tell. But I did a master's in public health alongside that.
Wow.
part-time. So I've done both the public health and the GP training.
Jeez. That was hard. Was it hard to juggle that?
It's a good time management planning, and like I say, a bit of a nerd.
I mean, you're obviously fairly intelligent as well, so I mean that helps probably.
Probably. And then and then I really got into lifestyle medicine as well, because I think that kind of merged the two. So that was kind of almost an individual aspect of public health. So that's looking at, say, nutrition, physical activity or movement, stress management, lack of addictive substances, so like drugs and alcohol, and social connection, but more at the individual level. So I did my International Diploma of Lifestyle Medicine and was the regional director of the British Society of Lifestyle Medicine for a time before, and then I gave up when I came here because you can't do everything. And then
unfortunately,
yeah. And I also,
it sounds like you'd like to if you could. Yeah,
exactly. And then I also did my yoga teacher training because I like that, more holistic care, and I found that interesting. And then I fully qualified as a GP and started this role 3 days a week initially, alongside practicing general GP, but with a special interest in women's health. And then I went up to 4 days a week here because I was really enjoying it. I like the variety and to be able to do more time to research and start my PhD. And then I still practice 1 day a week in clinical practice as a GP, but I do some general GP stuff, but I do a lot of, say, like initial consultations with women thinking they're perimenopausal and kind of talking them through the options, starting HRT if that's something they would like and is appropriate, HRT reviews, and I do pessary fittings. You were talking about pelvic, or you were talking about incontinence, and one of the main reasons for that is pelvic floor dysfunction and pelvic organ prolapse. So I fit pessaries, which is a conservative treatment option for ladies who do suffer with pelvic organ prolapse. So I have a slot in there for that, and then I have some face-to-face consultations as well. So that's Monday.
What is HRT?
Oh, sorry, hormone replacement therapy. Although in America and other places, and some people, researchers here, are trying to term it, or do use the word, menopause hormone therapy, because there's questions about whether it's a replacement to whether, because it is a natural physiological phase, so I'll be over medicalizing it and that sort of thing. So just, again, I think we've seen through all this, and that's something that I've come across as language is really important. So, terming things appropriately. And for example, that's one of the things I'm really passionate about in terms of women knowing their own body, is because actually, and then they can use the appropriate language. So like vagina is considered this whole encompassing thing, whereas actually it's the vulva, that is the outside bit, and that's the bit that women get most pleasure from. So actually, if you don't call it the right thing, you're kind of deminimizing it. But then also it's the language that medical professionals use to women in healthcare settings. So say, going back to that pelvic organ prolapse, if someone says, oh, I have urinary incontinence after giving birth to my child, well, saying, well, that's normal. Well, I don't think it's normal for someone to not be able to go on a trampoline, or every time they cough to, have urinary incontinence, or quoquely pee their pants. I think actually that's not normal. If a guy had that, he wouldn't expect that to be normal, but it is common. So actually saying, this is a common problem, you're not alone, but there are measures we can do to help you, support you with both education, exercise, and, pelvic floor exercises. See a women's health physio who are amazing, and then if you really are struggling, then we can talk about pessaries, which are conservative options, and then, yes, later down the line.
What are pessaries, sorry?
Oh, sorry, they're like, in the NHS, there's only the basic, obviously, but there are a whole load of different things, but they're either PVC or, again, privately in different options. There's silicone, so medical silicone is really good, but they're just devices that you pop inside the vagina to keep everything lifted up a bit more. So it's really empowering for women because they can self-manage. You can learn to take them in and out yourself. The ring pessaries. Is
it uncomfortable?
Sounds like if it's fitting properly, no. So you shouldn't feel it, but it should resolve your prolapse symptoms.
Right.
Sorry, I didn't explain what pessaries were, but yeah.
Okay.
No. So it's kind of going down that line that this is common, but it's not normal. Whereas if someone says, oh, that's normal, it's part of being a woman, it was your choice to have a child, when actually we don't teach women this is really something that can happen as a consequence of childbirth, I feel like, we're dismissing them and it's that language which is really important.
And saying it's normal implies that maybe you don't need to try and resolve the
or there's
issue.
Nothing you can do about it, or it's just part of being a woman. Whereas actually there are so many things we can do to help, and it's just being aware of that.
Where did you grow up? Go to school and all that?
Here,
Bournemouth.
Yeah.
Oh, me too.
So I was more like the southern west tip of the New Forest. So in a tiny hamlet, which no one's ever heard of, even if you live 5 miles away from it, but just the other side of Christchurch to Bournemouth.
Oh, I see.
And then I went to Oxford Uni, and then I came straight back to Poole. So I did my GP training and my foundation year training and my GP hospital jobs in Poole Hospital.
What school did you go to down here?
Camford.
Nice. That's a very
Drew
nice
that
school,
at me.
isn't it?
Yeah.
Sorry, yeah.
That's all right.
That's all right, isn't it? No shame.
Yeah.
Yeah. I'm guessing it wasn't your choice anyway.
No, I loved it and I
Yeah.
really enjoy it, but I just acknowledge the privilege. Put it that way.
Fair enough. Yeah.
Yeah.
I went to grammar school, so
Oh, nice.
similar kind
Cool.
of. But
Cool
obviously,
grammar?
Bournemouth.
Bournemouth, yeah.
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 So yeah, it's generally public enemy number one when it came to sports and stuff.
Oh, yeah.
Playing football against
No,
all the other local
it was
schools.
amazing. It's probably the happiest I've been in an education. Like, in terms of my education career, I really loved it. But I think it's very intense, like academically intense. And I think
Is it a boarding school? You
yes,
usually stay
I
at?
didn't board though. I was the furthest away living day kid because I think
Okay.
my parents liked us to be around and that sort of thing. But but very privileged, but really thoroughly enjoyed it. And I think it is hard work. I left home at 7:15 in the morning. I got home at 7:15 at night, and we went to Saturday school. So it's very, very privileged, very hard work, and gives you that ethos. But I think
And you're reaping the benefits of
Exactly.
that now, the
Yeah.
hard work.
yeah, and I think to be fair, I think I got that more from home as well because my parents are very workaholics, but in a good way. Like no, not workaholics. They're just very driven. But yeah.
All your sort of work seems to be focused on women specifically. Was that a conscious decision?
No, I think
Or-
it was again part of this journey. I think,
Yeah.
like I say, when I was doing more British Society of Lifestyle Medicine and Lifestyle Medicine Whole, that was very non-gendered at all. But I feel like I've just kind of gone into this space in terms of just the patients that were coming to me and what I became more passionate about and interested about. And I think it's really awesome to be able to use research for social change and good. And I feel this is a space where I can really be knowledgeable, but then be a bit of an activist as well and try and push forward social change through my research, through my medical practice. And yes, I run late all the time as a GP because I find it hard to not do my best at work and like find it hard that I don't get that job fulfillment by doing a bad job. And I feel like I've not done the best I can do, and that leaves you feeling really it's lack of job satisfaction basically.
So when you say, because you don't get to spend enough
No
time with each
how
patient.
can you educate women about menopause, give them all their options, check that HRT is not contraindicated, tell them all the other stuff about the genital urinary syndrome and menopause and what they could expect, and actually give that education and give a real holistic care, check their mental health, and really give them the time to answer all their questions and teach them all the different options they have, because it is a menu HRT. There are so many different options, and yes, some are not appropriate in each situation, but it's kind of then educating them why about all these different things. And how are you meant to do that in 10 minutes?
Are your time slots mandated then by
Yes.
above? That
Yes.
sounds like a political hot potato.
Yes, exactly. Exactly. But then how can you extend appointment times when there's only a certain number of hours in the day and we are always oversubscribed and always too many people to see? So I can see it. I think it's just the demand has outstripped the supply. So I tend to run late but then you've got that aspect of if you're doing 12, 13-hour days and your mind's just blown by the time you get home, that's not good for your life as well. So yeah.
Yeah, you need to look after yourself as well.
Exactly,
Yeah.
which is so I generally often do now half a day of GP so I can run late without it impacting my family life and home life, but obviously that's a pay cut by half of a day. Yeah.
Right. Do you have children? Do you mind me asking?
No.
But your family life isn't your
My partner. Yeah.
What was I going to ask? This always happens at one point in the
That's
conversation.
right.
I lose.
I can riff for a little bit.
Go on, yeah, you just riff. Yeah, maybe sing a song or something.
No, please don't. Like, you do not want me to do that. Yeah. No.
What are your sort of hopes going forward? Do you have ambitions? Do you have big plans in mind? Do you have like a goal or something?
I think like I've really enjoyed time at Bournemouth Uni, and I think progressing career-wise in the institution would be really positive. I feel like I'm very much an early career researcher. Like haven't literally just started my PhD, so I think getting more within the research world, trying to, like I say, do good with my research, so actually make a positive impact in society. That would be good, but I haven't really. I think I'm very happy with not knowing where my career is going in a, I don't have a 10-year, like I would love to like say work up Bournemouth Uni in terms of getting credibility within research and doing good and continuing the teaching and all that sort of thing. And I feel very stable in that environment, but exactly how that pans out, I don't know.
Okay, so you're fairly open, but
yeah, exactly.
You want to progress in some way, shape or
Yeah.
form. What is the Dorset Women's Health Task Force?
So that is a task force set up by women's Action Network Dorset, which when I do Women's Academic Network and Women's Action, there's two acronyms which are very similar, so I have to be careful, which is a charity trying to improve the overall well-being of women in Dorset, and there is health elements of that. Now, as part of the Women's Health Strategy, which was published in August of last year, they suggested having women's health hubs, which in my mind I was like, oh my lord, this is going to be amazing. They're going to be great buildings where you can maybe like pop your child into childcare whilst you have your smear, and you get this community, and it's just going to be a one-stop shop. It's going to be great. And then they said there's no funding for it, and you're like, well, how is this going to work then? And then they did backtrack and give, I think it was 25 million, but like 25 million for the whole country. And then they were saying they don't have to actually be physical buildings. They could be like a triage service, or they could be integrating what resources you already have. There's been some really great examples of women's health hubs. So long-acting reversible contraceptives called LARC, and they're things like the coils and the implants, things that don't require the woman to remember taking like a pill every day. There's no human error to it. There's obviously potential contraceptive failure, but it's not down to the I didn't take my pill at the right time sort of thing. And they did this amazing one in Liverpool to try, because there was a real increase in teenage pregnancy rates or unwanted pregnancy rates within that area in particular. But that was all down to GPs giving up their time and money and like energy to develop this above and beyond everything they were already doing. And I just don't think that's sustainable with the way that the healthcare is in system at the moment. So long-winded way of saying it, that's what women's health hubs kind of are, trying to improve the health of women as part of this women's health strategy. It's an action point from the women's health strategies to develop women's health hubs. And Women's Health Task Force, as part of the Women's Action Network, is trying to improve the health of women in Dorset. And the last couple of meetings we've had, because there's been a deadline to produce a business plan to get funding for the women's health hubs, is to talk about what would best serve the local community with the money that we might get. In like basically how big a bung can we get for our buck in terms of trying to improve the health of women in Dorset, to develop a proposal for a women's health hub. So that's what we've been doing the last couple of meetings, as well as trying to just generally, not thinking about the women's health hubs, but just generally, what can we do to improve women's health in Dorset? And there's been amazing input from academics, third-party sector, so voluntary organisations and charities, from clinicians and all that. And it's amazing from both primary and secondary care clinicians, so hospitals and GPs, and Sexual Health Dorset. And it's sometimes so... I tend to get a little passionate sometimes, but it's amazing sometimes how there's so much want to do good, and there's so much want and drive to improve the system, and sometimes it's amazing when you realise I didn't know you existed and I'm interested in the space and all that sort of thing, and then like trying to collaborate with each other. But again, it's political, there's bureaucracy, there's things in the way, but there's so much desire to support the women in Dorset with their health, but it's just trying to actually coordinate something to deliver that.
So at the moment you're in the sort of early stages of this.
Yeah, well, the business proposal's gone in.
Yeah.
So, yeah.
Oh, okay.
Because it had to be. But so we'll see.
Well, fingers crossed.
Yes.
We've talked a little bit about the NHS. We've sort of touched on the NHS. Can we talk about that from sort of a political perspective? Maybe you obviously work a lot in the NHS.
Yeah.
How do you feel in terms of the sort of funding? Do you feel like it's underfunded? Do you feel like maybe we mentioned population earlier? Do you think that's
solve the NHS?
Tell me. Yeah, what's the problem? What do we need to change?
I think there's so much.
Do you think it's a government thing as well?
I think it's so multifactorial. I feel there is a workforce crisis, both in terms of the number needed compared to the population demand, but also morality problem. Like the workforce morale is the lowest it's been for ages. I think there used to be an end point where, so for example, in the GP, you used to become the village town's GP. There was real respect both ways. Whereas I think media has a massive part to play as well. I remember in the pandemic, GPs were both this, and I think the past president of the RCP GP, so Royal College of General Practitioners, said GPs are both the saviours and the sacrificial. So we are both sacrificed and the saviours for the NHS, because we are often blamed for so much, but then also have to be the person to save it all. And I think that was seen very much in the pandemic, when there was so much bad press around being a GP in terms of we're just playing on golf courses, you know, we're shut and everything. Whereas as the GP, you were there all the time, and seeing patients, risking, like my partner's vulnerable, so in terms of from a COVID point of view, so risking taking that home, and lots of people are, and then you are trying to see everyone as much as you can, trying to keep yourself safe, and having people literally, you know, verbally, and in some cases not personally, physically abusing the GPs because they weren't seen when potentially probably given that situation appropriately, or even when they are seen. I remember I was like doing an abdo exam, so abdominal exam on a patient, and they were like, well, you're closed, so I haven't been able to see you. And I'm like, I am literally examining you, you know, and it's just that media. So I feel like media have a big sway on the public opinion. I feel like, yeah, there's a use of resources. I mean, it must be able to be done better. And I think a lot of it's bureaucracy and management, which takes so much time of the clinicians up, but also just makes it so inefficient that actually, I mean, to learn, I don't think they do this anymore, I'd hope, but as an F1, so first year doctor, the medicine I could do, my biggest query on my first day was, how do I fax? Because I had never learned how to fax, but I had to fax referrals. And you're just like, how can we have, you know, and it's like...
And what year was this?
2015.
And you're still using fax machines?
Yeah, and the confidentiality...
Is that still happening there?
I don't know. I don't work in a hospital. I hope not. But, you know, it's just like, yeah. So, not in primary care. But,
Right.
yeah, I think there's so much that could be done to improve efficiency. I think also from going to work abroad as well, in terms not working abroad, but volunteering abroad, and hearing stories from other family members who worked as a medic abroad in very much more deprived countries. People, I think, both really value the NHS as part of our culture, but I don't think necessarily they really value it in terms of they don't understand how much healthcare actually costs. So they therefore don't utilise resources necessarily appropriately, like going to the pharmacy and valuing the pharmacist. I went to get my, I went to get something in the pharmacy the other day, and there was like, they were doing a COVID and flu vaccine thing, and this pharmacist was on a Saturday so busy and so knowledgeable, and you think people just aren't using those. Well, they are obviously in terms of going to get prescriptions, but they're so highly qualified to what they are qualified to do, and doing so and we're taking it for granted. Yeah. And I think free doesn't mean worthless, and I think there is an element of that, and actually understanding the cost involved in seeking healthcare to use it appropriately, and to be able to give the education to people to try and keep their health in check. And that is that element of responsibility with a free healthcare system, I think, given challenges in lack of education, challenges in cost of healthy food, challenges in poverty and inequity, massive, not underestimating that. But there is an element of, if you have the resources, an element of responsibility with education to actually be able to look after your health to a certain point. But I think that's involved as well, to try and minimise the need to use a healthcare service if it's free.
It almost feels like the NHS requires more of a community feel from the whole country.
Exactly.
Which kind of came out a little bit in COVID, didn't it? You know,
it did. I think the clapping.
Yeah,
the clapping. But then it's like you clapped, and then a year later we were like the enemy again. And nothing. Yeah. So I think. And
there's murals like outside Bournemouth Hospitals and on the road. There's like, we love the
exactly.
NHS,
but then also there was like graffiti over it saying liars. So, you know, so yeah, so I had an NHS, when I was going to my GP, there was like a heart that said NHS 1 week, and the next week I went over it and there was just graffiti over it saying like liars and stuff. So you had, which feels great when you're going to work in a COVID pandemic. But I feel like, what was I going to say? I feel like some people do really, really value the NHS who've used it, you know, and I think that's great. But I think, you know, there used to be a junior doctor training is awful, but then I'll get to this great bit at the end, and I think the great bit at the end is not as great as it used to be. And I feel like, you know, people, I think the goodwill, I think people are being, government particularly, kind of are relying on the goodwill of clinical professionals, so doctors, but all allied healthcare professionals, clinical, to prop up the NHS. And I think that goodwill has run dry. I think that's one of the massive problems. Because of this whole system. And actually, people go to work to earn an income, and people who used to be in healthcare professional consultants, you know, GPs, had this quality of life that I think we can never aspire to. And I feel like that is a general generational divide anyway in the country, like politically and everything that's going on. But I feel like the pay has been eroded over the last 25 years. Like when I was coming into it, when I kind of signed up to be a medic in 2008, there is a significant disparity in line with inflation and other cost of living, what I would have been paid as a GP if the pay kind of kept going at 2008 level compared to what it is now.
Yeah. And as you say, I feel like people who get into this line of work are doing so because they have an element of empathy within
Exactly.
them.
Yeah.
And as you say, it's the goodwill
That's gone. And I think also
which is probably extended for longer than it would have done in any other industry.
Exactly. Yeah, and I think it's
because
like
you wouldn't see builders, for
exploiting
example.
that.
Yeah, it's fine. Yeah, we'll just keep laying
I'll
bricks
just-
and
yeah,
building
yeah.
roofs. Like, no, you're not paying us right.
No,
See you later.
exactly. Yeah, and there's that culture of, well, back in my day,
Yeah.
it's like, well, actually, it's changed in so many different ways.
But as you say, it's not also just the money, is it? It's also like the stature and the feeling part of that community and all
yeah,
that stuff.
and again,
This
that
stuff
job
is-
satisfaction that I wouldn't mind personally, and I think everyone's different, being paid, what I am now. If I feel like I could have done a good job and being able to provide fully holistic care with enough time to give to patients, but you don't get that job satisfaction from the output you're producing because of the systems in place, and then you don't get the financial reward, and it's like worst of both.
Do you think the NHS will still be here in 20 years' time?
I have no idea. I think the pinnacle we put it on, I think the NHS is probably not going to not be called the NHS, but I feel like the way it's actually produced and the way that it's funded might change. I know there's other countries, I don't think we really should go down an American way of insurance model because I think that's
terrible.
And yeah, exactly, and really emphasizes and
I think it was like a call out charge for an ambulance or something like.
Well, I mean, it's the same in the UK. It's the same in the UK. You just don't know it's £250 as soon as they put the blue lights on. You just don't know that.
No.
But I feel like that really exaggerates social and health inequalities. So I don't think that's great. But I feel there are other models that might work well in terms of like social insurance and other things. But I don't know how the NHS is going to look in 20 years. But I can't imagine us getting rid of it as part of how big a part of society it is.
I hope not. Yeah, as you say, it's based on the principle, we look after those who are less fortunate and who can't maybe afford or whatever. And I know there is already, there's a lot of private healthcare around.
And I think lots of people are going more private these days if they can afford it because of the long waiting lists and that sort of thing, yeah.
Yeah. So I guess maybe that's probably the future, isn't it?
I don't know, maybe. Yeah, I don't know is the answer.
That's very honest of you. These damn academics, they don't give blunt answers if they don't know something. They just say they don't know. It's impossible to get. Okay, that's great. I mean, is there anything else that you'd like to add? I've really enjoyed this conversation. This is probably one of the conversations I've learnt the most from, especially about all the bodily parts and their names.
Yeah. No, sorry if any I didn't clarify, you might just put them in the show notes or anything that I just kind of went on. No, I think that's great. And I'm always, I could talk about this all day. I think that's the thing. And I think, there's some things I'm obviously more passionate and knowledgeable about than other areas that we've talked about. But I think, that we've covered there's nothing I think, I haven't talked about that, if you know what I mean.
Oh, that's great. That's good to hear.
Yeah.
I've done my job then.
Yes.
Hopefully. All right, Dr. Emma Thurston, thank you so much for joining me on the podcast. It's been a real pleasure. Good luck in everything you do.
Thank you.
Inspiring many people and women and like you say, being an advocate for women's health, I think is really super important. And as I say, it was eye-opening to me to see that journey that women have to go through that's different. I don't think you ever actually finished the journey thing. I interrupted, didn't you? Didn't I? But we're not going to go back there now because we're finished and we're wrapping up. I'll maybe clarify that in the notes or something below. But thank you so much. It's been an absolute pleasure.
More than welcome. That's great.
Cool. So Emma, we said bye and everything, and I forgot. Well, you reminded me. Thank you. Right. You know the show better than I do. That we forgot the segment that I always do on this podcast, which is to get guests to bring in a meaningful image. So this here is your meaningful image. Is it local?
Yes. So
for those listening, by the way, it's a landscape shot. Sorry to interrupt. There's a tree in the foreground and some sea and some nice cliffs and stuff. So you talk to us about that.
So that's in Devon, which is
Can you push your mic slightly?
Oh yeah, sorry. That's in Devon, which is one of the places I love going to and having some holiday in and going for hikes. And the reason why I chose this picture when you asked me to bring something meaningful is I think it's really important whilst you're trying to be really embraced in doing good in the world to have some time out. And so that's one of the places that I go to fully unplug and turn my emails off, everything. And I love going for walks, hikes, and this is taken on a hike. And I think I was talking about being an advocate of lifestyle medicine. I think being out in nature has been shown to be really beneficial for our health. There's some fascinating work done by Japanese medical school and Japanese centres of research in Shinrin-yoku, which can be roughly translated into forest bathing. So it's really being immersed with the five senses in nature.
Okay.
So I think that's one thing that I can do on walks, is really unplug and be in nature and use that as a moment of mindfulness. There's also some work done by a really interesting book called Blue Mind, which is about how being in, on or near water is really good for our health as well. So that kind of encompasses both being on a coastal cliff hike and how doing what we call green exercise, so that's exercise in nature, is synergistic with being in nature and general exercise. So you get that synergistic benefit to health, both mental and physical. And I feel like, again, thinking about the pillars of lifestyle medicine, I love going on walks with people, usually like just one or two people, because then you can get really in-depth conversations and it really improves your social connection. And I feel that's one of the things that I often do with my partner on holiday in Devon, is we do it every week anyway in the forest, because I'm lucky enough to live in the forest. But unplug. So you've got your phone off. You can really have deep, meaningful conversations. You're often side by side, which makes any challenging conversations less intimidating. But you can just get into lovely conversations on a walk. So I think that's one of the things why I chose that pace. The other thing is that it's a really bad photo, because I was trying to be in the moment. So it's kind of teaching me as well I really wanted to capture the moment, but I really also wanted to be involved in the moments in real life. So it's a photo, but it's not the best, because I was trying to really be in the present. I think it's a teaching point to be in the present and not always be on our screens or looking through, screens, but just be present in the moment. And why there is because that is a really beautiful tree that I didn't capture. But 10 days ago, I got engaged under that tree.
Really?
Yeah.
Oh, congratulations. God, now I feel really bad that I forgot to talk about this. Oh, congratulations. That's amazing. Well done.
I didn't do anything other than say yes. It's more
well, and cultivate a lovely relationship, I imagine. Since we're just talking again, you're mentioning these sort of benefits of being outside and stuff, and you also mentioned that you do yoga or teach yoga. Do you actually teach yoga?
So I've done very minimal teaching, but I did do the teacher training both in Vinyasa, which is more like flow yoga, and Yin, which is more from the Chinese heritage in terms of holding poses for a long time, and then you really have to be more mindful and in the moment and present in your body. So I have done the qualification, so the 200-hour in Vinyasa yoga and the 50-hour add-on Yin yoga teacher training, but I don't tend to teach. I tend to actually really enjoy yoga as something that's kind of just for me, and I find that when you're teaching yoga, you're focusing on the teaching rather than actually being embodied. So I kind of like it as an individual practice. However, I have done some sessions, particularly for the GP centre, so the Dorset GP training scheme, as part of like providing them with some like mindfulness, some life skills, some resilience skills. I've kind of done some breath, because I'm also a breath coach, so done that breath coach training. So done some breath work sessions with them and some yoga sessions as part of that like holistic wellbeing for GP trainees. But I don't tend to teach that much, no.
You lead such a varied life. So I think it's a dangerous thing when something that you do for pleasure becomes work as well.
Yes, exactly. And I was trying to kind of, I think doing the teacher training was really good for my own individual practice and deepening that. But I feel it's really important to have some distinction between what you do for pleasure and what you do for work.
Do you find it easy to switch off when you do yoga?
It's one of the best things for me to switch off. I think,
You strike me as someone who doesn't switch off much.
It's one of the times where my mind does stop, because you're, particularly when you're doing challenging poses, if you stop focusing and you stop contracting your core, if you're doing balance work, you're going to fall over. So you really need to be embodied in that moment. So I feel like, it's one of the times that you never regret a practice. It's like you never regret a workout. So I love working out as well. And I think I don't always like the person who goes on the mat, but I always like the person who comes off the mat, is kind of a way of putting it. So if you're stressed or you're annoyed or something, if you just get on your yoga mat, that's what I find, it always does the job.
That's a lovely way of putting it. I think that's a nice ending as well.
Okay.
Yeah, you need to blue tack that up on the wall.
Okay.
Would you like to do that now or
I
when we finish?
That when we finish.
So you don't show your ass to the cameras yet.
Yeah, exactly.
That is the real ending there.
Yeah.
So thank you thank you very much, I should say, for everyone for listening. Sorry, I forgot the segment that I do every time on the podcast, but thanks, Emma, for reminding me.
Right,
and thanks again for the lovely conversation.
It's been a real pleasure.
Thank you.